What is going on, guys? This is Dr. Ryan Garner with Apothicor Wellness. Today's video is part of a series in which we do an in-depth analysis of a patient case. This is beneficial for our current and future clients, as well as other healthcare providers, just to get some insight into our approach on a way to maximizing patient outcomes, utilizing the most up-to-date data and evidence, as well as the lowest cost drug regimens possible. So let's go ahead and jump into it. Our patient today is CS. She's a 60-year-old female. She is 67 inches tall, so about 5'7". She weighs about 163 pounds, has a BMI of 25.5. She has a 10-year ASCVD risk, or our cardiovascular risk, of about 2.5%. The only diagnosis she has is a history of asthma. Her current APGAR score is about 2. It is a tool in which we can monitor asthma control. Has been studied and verified to give an accurate assessment of asthma control at current. Her current medications include QVAR 40 milligrams, 2 puffs twice a day, montelukast 10 milligrams, 1 daily, as well as an albuterol inhaler, doing 1 to 2 puffs every 4 to 6 hours as needed. Now, patient claimed to me to have symptoms less than 4 to 5 times per week, and this would kind of put her in the mild to moderate asthmatic range. However, her field history does tell a little bit of a different story. She is picking up her albuterol pretty frequently and does admit that she is not as on top of her QVAR as she should be. So a lack of adherence there is certainly a driving factor for the increased need for her albuterol. She's picking up each one about every 5 to 6 weeks. As always, we're going to identify things that don't need to be on board and things that we can improve on. Now, we do have data that shows the superiority of inhaled corticosteroids over leukotriene receptor antagonists like montelukast. So we know that we can't just discontinue the inhaled corticosteroid. The initial trial and other meta-analysis have also shown an improvement with montelukast on board, but not statistically significant when added to an inhaled corticosteroid by itself or with a long-acting bronchodilator. Because it's not statistically significant, we can't say for sure that this patient would benefit by having montelukast on top of her current regimen. Now, we do need to address the patient's lack of adherence to her QVAR. Inhaled corticosteroid is the foundation of her asthma therapy. Now, because patient is between the mild and moderate steps when it comes to grading her asthma, we could potentially switch to inhaled corticosteroid and long-acting bronchodilator like a Symbicort or the generic budesonide and formoterol. Now, how does this work in lieu of something like an inhaled corticosteroid and albuterol? The idea is that if a patient is needing their albuterol inhaler, there is more inflammation than we want in the airways, and increasing the amount of steroid the patient is getting is necessary. We have an abundance of trials like Sigma 1 and 2, the practical and novel START, that show a non-inferiority compared to maintenance steroid inhalation as well as albuterol. And this approach didn't necessarily improve symptom control compared to the standard therapy, but it did actually reduce the number of exacerbations that the patient had. One of the great things about moving to an as-needed steroid long-acting bronchodilator combination is it actually reduced the amount of inhalations the patient needed. Therefore, for this patient being less adherent, we should get better outcomes than current therapy. In fact, these studies showed about a quarter to a fifth less inhalation doses as compared to standard maintenance therapy. That patient also mentioned to me that she hadn't reviewed an action plan for some time. So that's certainly something that we need to get on board and regularly check in with and follow up on. The action plan that we suggest also includes having oral steroids on board for any exacerbations that can be treated outside of urgent care or the emergency room. And the action plan does give the patient guidance on when to initiate this. It also includes patient regularly utilizing their peak flow meter, as well as a pulse oximeter to measure oxygen saturation. So what is the plan? We're going to discontinue the patient's QVAR, and we're actually going to discontinue the patient's albuterol. We're going to discontinue the patient's montelukast as well. We're going to initiate budesonide with formoterol as needed, not to exceed 12 doses in a day. We will adjust this depending on any kind of follow-ups and any kind of scoring on symptoms going forward, whether we need to step up to maintenance as well as needed with this current medication, or we can remain just using it as needed. We will get the patient a prednisone 20 milligram prescription on file to do 2 daily for 5 days, according to action plan. We'll also get the patient the pulse oximeter as well as a peak flow meter. And we'll also be reviewing the patient's action plan with every follow-up, as we always should be doing. So what do our costs look like? Well, for the budesonide formoterol, we're looking at about $650 a year. Now, that is assuming that the patient is only utilizing about a quarter of the doses compared to maintenance, which would equate to about 3 months of fills. What do our savings look like? For the montelukast, it's somewhere around $104. For the albuterol, we're expecting about $300 a year in savings based off the frequency that the patient was filling it. And as for the QVAR, the pre-rebate savings is about $2,400, and the post-rebate savings is around $1,500. Now, for the total savings, the pre-rebate dollars looks like about $2,100, and the post-rebate savings is about $1,250. Now, as always, rebates can fluctuate, depends on who's negotiating those rebates for you, how much the PBM is retaining, and certainly the class of medication. Medications that have more competitors will offer higher rebates for formulary placement, and other classes that have fewer competitors will offer lower rebates. And this is a case where we do expect much greater outcomes for this patient, as adherence was an issue for them, and the number of albuterol fills in the year certainly put them at risk for future exacerbations. So not only are we minimizing potential urgent and emergency room visits, we are also able to find about a $1,200 to $2,100 savings in drug costs per year for the client. As always, thank you for tuning in. Don't forget to like and subscribe and follow us on LinkedIn.